It's my pleasure to once again be chairing this session. It's going off and on. I'm sorry. IT, can you just make sure that we're not dropping on these mics? Okay, this is the session on strengthening integration for better SRHR outcomes. My name is Lydia Zigomo. I'm the Regional Director for UNFPA for East and Southern Africa. And it's my pleasure to be chairing this session. We're going to be exploring the linkages between unintended pregnancies, unsafe abortion, and HIV, women living with HIV, and women living with HIV. And the main context is actually going to be around what these speakers are going to be focusing on, which is an assessment that was done in 4 countries in the region: Botswana, Eswatini, Lesotho, and Namibia, but zoning in particularly on the experience in Botswana, to outline a strategic approach to provide a comparison of the key elements of the background papers that were shared, showing how, through a comparison across countries, we can think, we can have a regional thinking around strengthening health policies and programs in the areas that I've just talked about: unintended pregnancy, contraception, comprehensive abortion services, sexual and gender-based violence, and HIV. My panel is made up of 4 speakers, and they're going to present in 2 lots. The first will be Dr. Janaka Sitole, Technical Officer for RMN CAHN. I know what some of those acronyms mean, but she can tell us more about them. But WHO, so mother newborn, I think, and neonatal services in Zimbabwe. Second will be Professor Catriona McLeod, Rhodes University, regional consultant for the development of the background papers for the strategic assessments in Botswana, Eswatini, Lesotho, and Namibia. And a colleague of ours from UNFPA Botswana, Kesa for short, SRH and HIV linkages coordinator. She's also the regional technical assistant specialist for the strategic assessments. And lastly, we're going to get, of course, always a voice from the community. Yvette Raphael, Executive Director for Advocates for Prevention of HIV and AIDS in Africa, based in South Africa. Welcome to all of you. And I'm immediately going to hand over to the 3 first speakers to begin the ball rolling. Over to you, Dr. Janaka.
Thank you very much, and good morning. I'm going to speak to the WHO strategic approach that has been, that has been adopted by the countries that are going to present on the work they did. So by way of background, the WHO strategic approach is a process that can be used by the countries to identify and to prioritize the needs for sexual and reproductive health, programs, policies, and research. So it can also be used to generate the national mandate for actions, as well as to test the appropriate innovations to address the priority needs for the country. So basically, it unites the concepts and the practices from the public health and the social science. So it is grounded on certain principles of ICPD, such as the systems framework, which examines or assesses the relationship between the people, the service delivery system, and the characteristics of the available health technologies in the country. So this systems perspective serves as a reminder to us that the ability of a new technology or a service to improve access to the quality of care should be evaluated in the context of the overall system and not on the merits of the intervention itself. So there are also principles that it values this approach, like the reproductive health philosophy of reproductive rights, the gender equity, and empowerment. But it mainly focuses on improving access to and the quality of care so that the services are client-centered and they are responsive to the community needs. It really values the country ownership. So the approach places the decision-making in the hands of the national participants. That means that the donors, the technical agents, they just play a partnership role. It is also, this process has 3 stages of implementation, and the first stage being the strategic assessment. So the strategic assessment examines the current situation and the alternative approaches to resolving an issue that might be in a country. So it also has the processes that are under it, like the development of the background report, which allows the gathering and the analysis of the existing information, which then arms the decision makers with as much factual background information as possible. And in this stage, this is where we also do things like the national planning workshops that should be inclusive and non-sectoral, and also the field work. And the second stage involves the development of the policy and the action research to pilot test the interventions based on the recommendations that will be drawn from the assessment, that is the stage 1 strategic assessment. And after that, the third stage follows. So the third stage mainly focuses on policy change, scaling up those successful interventions that we were testing in stage 2, and also putting into consideration the results from stage 2 and also the lessons that we would have learned from the stage 2 of pilot testing. So basically, this strategic assessment is a valuable tool that can be used to integrate SRH into the broader health and development programs. And how is it being done? It facilitates evidence-based decision-making, facilitates stakeholder engagement, capacity building, and allows the monitoring of the progress, as well as holding stakeholders accountable, and ultimately contributing to the improvement of the SRH outcomes and overall health for all. So in a nutshell, that's the WHO strategic approach that has been adapted by the countries that are going to speak after me and then tell us how they have adapted it into their own context. So I will leave this time to Prof.
Thank you very much. That's a very thorough explanation of the entire process. I am just going to take you through some of what we've done in terms of the background papers, because those were the starting points. Already know in these 4 countries, and the 4 countries we're speaking about are Botswana, Namibia, Eswatini, and Lesotho. And so colleagues and I, we were commissioned to do the background papers. And I think what was really, what we learned from this is that there's possibly more information out there than we realize. When you do a thorough search, which we did, looking at databases and doing country visits, you actually manage to surface quite a lot of information. And so the purpose of this, of these background papers, was to inform the strategic assessment. What is it that we don't know? What is it that we want to know more about? How can we use this information that we already have to start thinking about a strategic approach to integrating and improving SRH in general? So that's what the background papers do, and it takes a very holistic approach. So the analysis is in terms of people. Where are we at in terms of various indicators and services, then to see what is happening in terms of services, but also in terms of systems, so policies and laws, etc., and how all of these 3 things speak to each other. So it's quite a holistic analysis that is done. What I'm going to show you now is actually what we went a bit further than just doing the background papers for the 4 countries, because that can inform, obviously, the individual countries. But we started then, we looked at the background papers, and we looked across the countries to consolidate what is it that we can find that can maybe tell us regionally, if we start doing this comparative work, and what is it that countries can learn from each other? And so that's what I think useful sort of systematic comparative work helps with. So this isn't now what I'm showing you now. I'm going to be really brief because there's a huge amount of information in the background papers and also that we drew on in terms of writing this paper. We wrote a comparative paper that's published in Global Public Health, and we used, the framework that we used is a reparative justice framework, and basically what that does is it looks to see what is it that we know, where are the problems and what needs fixing and how do we think we can fix them. Is this on? Yes, it is on. Okay. And so don't worry too much about the framework. It is there. You can read about it more if you are interested in the actual paper. But basically, again, it tries to look holistically. It tries to look at the individual level and at the collective level. Collective meaning quite broadly society, but also government, civil society, etc. And also then at the material level, things like resources, services, but also the social. And I think that's something that we've heard a lot about at this conference, is how the social issues around stigma, around power relations, interpersonal kinds of ways of interacting are equally important as the resources. So this framework looks at kind of four dimensions: individual, symbolic, individual material, collective symbolic, collective material. And so we went systematically through each of these levels, comparing the four countries. So if we can go on to the next slide, I'm not going to go through each of them, but it just gives you an indication. So this is at the collective material level. You can see that we looked at each country. We've got key kind of findings that were surfaced in the background papers, and then some indication of what would be the remedy, what would be potential things that could be put into place in order to address the particular things that we're talking about. I'm not going to look through all of this. As I say, this is quite a lot of information. If we can go on to the next slide, and then the next one, I want to get to the one where we look at, is it got correct? No, the next one, please. Go on to the next slide. No, the one before that. Sorry, two before that. Two before that, and one more. Okay, thank you. No, sorry, there's one in between. I'm very sorry, but this seems to be the one that says pregnancy-related death reviews at the top. It's one down. That's it. Yeah, okay, pause there, please. Okay, so I'm just focusing in on legal abortion services. Now, just remembering that abortion is legal in these all four countries under certain grounds. It's restrictive legislation, but it is legal under particular grounds. Okay, so the kind of argument here is where it is legal on grounds that it is legal, it should be available. And so part of what we did in the background papers is to look to see, and this now shows you the comparative method and how it works. So for Botswana, we could find no information, unfortunately, so there's information needed there. In Eswatini, there were only 11% of facilities provide manual removal of placenta, 14% provide post-abortion care. In Lesotho, 11 of the facilities provide a full range of safe abortion care, and 18% of hospitals, etc., no guidelines for induced abortion. In Namibia, the majority of abortions are performed in state hospitals only. The abortion care registers are available, 40% in national hospitals, 37 in district hospitals. So here you can see the kind of detailed information across all of the countries. And what would be a kind of overarching remedy that we could think of across the 4 countries? What we've got there is increased facilities and staff able to offer safe abortions under the legal circumstances within the country. The fiscal was important, and human resource planning and upskilling of current reproductive health staff, keep up-to-date abortion registers. So this gives you an indication of the kinds of processes that we went through. I'm just using legal abortion as, or abortion under legal circumstances as an example. So can we go on to the next 1, 2 slides? The next one, thank you. Okay, and what was important with this whole process was to particularly have an intersectional approach. So when you're looking, for example, let's say abortion, it's clear that you want to talk about contraception, it's clear that you want to talk about unintended pregnancies. But sometimes things like gender-based violence or HIV may slide off the table when you're making, approaching unsafe abortion. And so it was important, and here we just have a quote from this paper, it's important that the needs of particular pregnant people are noted in comprehensive abortion care guidelines. For example, given the high prevalence of HIV and the reasons for needs of pregnant people living with HIV, for information on options both concerning safe pregnancies and safe conception, we may say, and safe abortion should be considered in devising policy and implementing services, and the needs of young people in relation to abortion, including privacy, non-coerced decision-making, particularly in relation to parents and non-judgmental service provision should be considered. So I'll leave it there as just an indication of the importance of the integration of these issues. Thank you.
Okay, thank you. I'll take it from here. Next slide, please. ICASA is introduced. I will now share the experience of Botswana in applying this framework that Dr. Sithole has so ably described to us. So we're focusing on the first phase of the strategic approach, which is the strategic assessment. It's already been described. Next slide, please. So what we want to showcase is the participatory nature of this process, which is a stacked process, even at that first stage of the strategic approach, and that this is a truly stakeholder and a country-led exercise, as described by Dr. Sithole, starting with the planning workshop, all the way to data collection, and then prioritizing the recommendations for action, which will take us to step 2. Next slide, please. So in Botswana, once the background paper had been done, the national stakeholder consensus was made that the 3 areas that we wanted to explore more as we move into speaking to the communities, to policymakers, to the gatekeepers and providers were on these 3 thematic areas. The background paper had noted high rates of unintended pregnancies, especially among the youth, reports of maternal deaths due to unsafe abortion, and the continued rise in pregnancies despite the national resources put into SRHR. So stakeholder consensus at national level was that we were going to explore more around unintended pregnancies, abortion and abortion services, including safe comprehensive abortion care, and then family planning and understanding the dynamics. And of course, the cross-cutting issues of integrating HIV and sexual gender-based violence. In setting up this work, we had the national stakeholders come together in a workshop to, of course, look at the background paper and then decide on those thematic areas. A national assessment team was set up, a team of 14, and this is guided by the methodology, and this is the team that will then proceed to the field work to explore more. We developed the study questions or assessment questions and tools, and went ahead to train this national assessment team in terms of data collection and work with this team to identify the potential respondents as well as all of the areas that we would like to. And of course, in this process, we had to follow due process. This is an assessment. We're going to talk to people, so get the appropriate clearance with ethical bodies. In terms of, next slide, please. Next one. I forgot to say next slide. Thank you. So in terms of how we selected where to go, the idea was to ensure that we have a meaningful coverage of the country context to ensure that there's diversity in terms of the views that we would get from the stakeholders that were identified as respondents. So we looked geographically, the semi-urban, urban divide. We looked at the socio-economic development levels of the different regions of the country. We looked at also the diversity in terms of cultural practices across the different districts. Botswana is a small country in terms of population, but quite broad in terms of area and is quite sparsely populated. So we needed to make sure that we're hearing from all four corners of the country. And also we looked at the burden of teenage pregnancies and abortion admissions. Next slide, please. So once this was done, these are some of the considerations, and we like to share this information, especially for countries that are looking to conduct a strategic assessment, their approaches and tools to move forward from that national stakeholder workshop and consensus building into now the field work or data collection. And what you see there is a copy of the report from the assessment. There's overall coordination that's required for this work, technical assistance which is coming through us from UNFPA and WHO and other sister agencies in the country, the application of due diligence to make sure that we are covering all the bases from a compliance perspective, but also in mobilizing stakeholders. Logistics, you're going throughout the country in teams of people, and we need to make sure that there is overall coordination. Have your data tools, gadgets that we would use. This is an assessment that collects views on a qualitative point from the community all the way up to policy level. So we need to make sure that we have those assistive devices. And to collect and then have the report. And this work is done also via the support of a consultant who would then collate all the data and draft the report, which is then validated by the national stakeholders. We then reconvene the national stakeholders to look at the recommendations, because you come out of the field with a lot of rich data, a lot of recommendations, and to say, as we move from stage 1 to stage 2, what can we prioritize based on what are the most pressing needs? Next slide, please. Beyond the assessment report, which you saw on the previous slide, we went further to look at the specific thematic areas of the assessment and the recommendations, and decided to develop policy briefs out of each of the areas to ensure that we have a tool and advocacy material that we would use specifically for policymakers to outline what are the options for and opportunities for improving the uptake of contraceptives, reducing unintended pregnancies, and preventing unsafe abortion as a means to reduce maternal mortality in the country. This is also forms part of our knowledge sharing program, as well as for easy dissemination. The report is quite bulky, so the policy briefs as a 4-pager assist in that case to be able to reach the audience. We've shared the tools and the approaches with other countries in the region, currently supporting Lesotho, which is going through a similar process, and so those approaches are really helpful to make sure that we're not starting from scratch. And we are also working on the final stages of a publication of a journal article from that assessment. We have, as Botswana, next slide, moved to stage 2 as of last year, which is now implementation of those recommendations. Next slide, please. Next slide. I'll keep talking. And then you go to the next slide as well, that says strides. What we want to share, next slide. What we want to share is some of the strides that we're already seeing from the implementation of these priority recommendations, as well as some of the factors that the contextual changes that are happening in the country that would actually enable or fast-track implementation of this. From a legal and policy perspective, for instance, there's been a couple of reforms in the country. We recently had rationalization of ministries. So those recommendations that are related to how do we really advance the agenda on gender equality and women's empowerment, we see this as an opportunity where women will be able to be supported in entrepreneurial, where they embark on entrepreneurial activities to ensure that we can attend to that challenge of gender inequality and empowerment of women. There is other, economic empowerment activities going on in the country that have really bolstered the opportunities for women's empowerment. In terms of policies, we are currently at the final stages as a country of revising the National Education Act, and it's really noted the high rates of teenage pregnancies, and it's looking at ensuring that we can facilitate via this act and the policies and the strategies that would follow to improve SRHR for young people. We have, as a country, endorsed the ESA commitments, and we are currently working on implementation of the priorities for those commitments. So ESA commitments have identified HIV, ST as SRHR, so there's a strong SRH agenda there that would be able to support from a policy perspective. Recently, as a country, we've had a penal code amendment, which among others looks to protect SRHR by ensuring that sexual offences are appropriately penalized. And there is many more. I'll just go to the next slide to save time. In terms of provision of quality access to services, there were so many recommendations from the assessment around improvements in the justice system, including for access to justice for violated children. So there's been a lot of work with our sister partners, UNICEF, working with Botswana Police to really strengthen that area to ensure that justice is not delayed for children and adults that need that preparation. There's capacity building that's taking place, as well as working with Botswana Police and other stakeholders. And from the health sector, we have really strengthened the availability of guidelines for integration of services, SRH, HIV, and the whole RAMPA continuum of care, as well as revise the guidelines on GBV, and we'll be starting the trainings of healthcare workers to ensure that they can identify and manage cases of GBV. Advocacy level, this is my last slide. We are looking at leveraging some of the upcoming platforms that are in place. We are currently supporting the country to roll out music for SRH, and this is an opportunity to really integrate as well the whole RAMPA continuum, HIV, AIDS, and GBV. And also there's a lot of work being done around awareness, and this is our work that our sister agency UNICEF is doing with the police. So I want to stop with this slide. Next slide, please. And next one. I'm busy moving my slides and not moving the ones. Next one. So this is the concluding slide where we just highlight some of the key words that speak to the possibilities and challenges with the process. The process definitely fosters integration. It's integrated. You're bringing all of the partners together. We are integrated from the panel. This is work that WHO and UNFPA collaborate on to support the government on. It's intersectional. We look at that whole lens, looking at vulnerabilities and cross-vulnerabilities across population sectors. It's highly participatory, and the consensus is felt at national level. It's comprehensive in its nature. It raises awareness. So part of what you're doing is you talk to the people, if you're able to offer some of the answers. For instance, when we look at the questions around knowledge of the legal framework on abortion, you use that opportunity to articulate that legal framework where you identify within with key informants that there is a lack of. In terms of challenges, it is a time-consuming process to move just from the background papers to the field work. It can be quite expensive as well. You're sending a team of 14 to 20 people in the field to talk to these stakeholders. Some groups might be silenced, but some groups might speak up. We found in this process that we were able to have meaningful conversations around some of these sensitive topics, such as abortion, contraception, with diverse groups of stakeholders. And so it's important when you go through this work also to mind the language sensitivity. And I do report just the past few weeks we're supporting the suit with this work, just how it's important that even with the terms in English, whether it's abortion or termination of pregnancy, but when you go to the field level and talk to a traditional leader, a chief, or to a faith-based leader, how do you adjust your language to still articulate these issues and make sure that you can get meaningful contributions from them? So this is where we stop. Thank you very much.
And you're the one who said you wanted crowd participation. You've taken up a lot of time, but it was important. So I'm going to immediately ask Yvette Raphael to take the floor and speak from the community perspective.
Good morning. I think it's afternoon already, or so good morning. Good morning, everyone. As mentioned, my name is Yvette Raphael, and popularly known as Auntie Pause. I think for me, just listening to the presentations from the stage up here, my immediate reaction is, who is this data intended for? Is it intended for policymakers? Is it intended for funders? And is it intended, or is it also intended for young people? Glaring before us is the non-inclusion of young people in this discussion and the work that we are doing. And I do know that we recognize that I'm an advocate and I represent the community. We cannot talk sufficiently about dealing with unintended pregnancy or contraceptive or HIV prevention without dealing with the structural barriers and issues that young people face. I think it's important for us to always, when we do this work, include young people so that we hear in our policy brief, in the papers we intend to write, to hear from the young people, and also to take into consideration some of the structural barriers that they deal with on a daily basis, and only young people can tell us that. Policies are there, but unless these policies are really implemented, young people will continuously be targeted and not bear the fruit of some of the work that we do. Service delivery should also include young people by having young people part of the work that we do. But the young people should not only be seen as beneficiaries of the work that we do or recipients of the work that is going on, but also to give great input in some of the work. Integration of services is important. However, I have almost like an energy, colleagues, if we talk about integration of services, but we do not take into account that young people face the might of these services that are meant for them, but whether it's the healthcare workers, whether it's the police. I heard the word police quite a few times here, and immediately I got scared, because if we involve the police without speaking to the young people or without taking into consideration what the outcomes thereof might be, is put them further in danger and being stigmatized, one, and be targeted. When we talk about sexual and gender-based violence, we also need to start thinking, who is perpetrating this? Is it the young people? Why are our papers not looking at how do we, I'm going to say this, how do we teach men not to rape young girls? Because that is exactly what it is. We give it a policy name, unintended pregnancy, but most of the time, these young people are impregnated by men much older than them. So we need to deal with some of those issues. Like I said, programmatizing the lives of young people can be a great danger for them. The lack of people-centered, and when we talk in this space and we talk about SRHR, if we do not include young people in the work that we do, who are the people who are at the center of this, we will not deny actually young people of their human rights, of their health, the right to health. And we know what happens when young people access unsafe abortion services. You don't only take they are not only in danger, but you take away their rights to grow up as childbearing young people if they choose to do so. We must know that these dangerous services that are offered for young people oftentimes put them in danger of losing that reproductive right that they have. When young people don't feel safe, they will not access our services. So what do we do to ensure that young people feel safe to access services? Is by appointing other young people in those spaces and including them. And I don't hear enough about that. We have nurses very, I don't want to say old because I'm also getting there, but we have nurses that should be mentoring these young nurses. Instead, they're still the ones talking to young people, and young people are afraid to access the service. Working with the police as I mentioned, can further put the lives of young people in danger and their parents. We know in the countries that we work in that sometimes the parents are part of this deal with older men. When we receive these young people in healthcare services, we know that the family has probably approved of a young person getting, married by an older man. And because we're in Africa, we are allowed to speak about this. One of the challenges is child marriages as well. We give it a name, but actually what it is rape. We need to start thinking around how do we gather information where these injustices towards young people continue to happen. Thank you.
Thank you, Yvette, and passionate advocate there, and advocate for youth inclusion and really pushing on these strategic assessments to look at how inclusive they are in the conduct, in the process, and even in the implementation of the outcomes of those assessments. I think we've unfortunately come to the end of the time for this session, so we were hoping we'd have enough time, about 15 minutes for audience participation, but as usual, there isn't, and I'm not sure whether there'll be another group coming in. I think one recommendation for sure from this conference is that 45-minute sessions are probably a little bit too short to enable crowd participation. We probably need at least an hour, so that then you can really guarantee that 15 or 20 minutes to speak. But as I wrap up, I wanted to, I was just reflecting on all the presentations. And I'll offer some concluding remarks for your reflection, internal reflection yourselves, and for looking at for wherever you come from. I'm struck by a number of things. I wondered about these strategic assessments. I think they're great. It's appreciation to WHO for initiating them and the work that's been done with other agencies like UNFPA, UNICEF, and others. But I wonder to what extent we can move beyond continue to spend so much money on these types of assessments to making them part of the health management information system, and also the way in which we assess services in general. How do we move this to be an integral part of health system strengthening? And what we talk about as universal healthcare and primary healthcare. Because the more we can do that, the less it becomes an add-on to an existing system, and an add-on process that requires additional funding and resourcing of human resources and everything else to run them. Because in resource-poor nations, I think we have to think about what scalability looks like and uptake looks like. The other aspect that struck me is a little bit actually about what you say, because I was thinking about, we say we're doing this for better SRHR outcomes, for better sexual reproductive health and rights outcomes. And it was clear from the 4 countries that have been talked about that we have youthful populations, and the better health outcomes in terms of sexual reproductive health and rights that we're looking for, and for HIV, are actually among young people. And I was, as also a lawyer, so I understand your fear of police. But as a lawyer who's worked in these types of countries, I wondered whether what we're doing addresses also how we make it. So it's not that it's not important, but how do we get there to the place where we are able to look at what's happening in young people's lives? Because one thing that struck me from all the sessions that I've taken part in is the late presentation by young people to the health services. So health services are, however much we improve them, are only going to be helpful to a young person if they present early enough for that health intervention, whether it's from a prevention perspective or from a treatment and care perspective, to actually make a difference in their lives. If young people cannot or are not presenting early enough, then the problems will continue. So one of the things I wondered is, how do we get that to change in this environment, which is to a great extent youth unfriendly and disabling? Because if that environment doesn't change from the point of view of schools teaching and families learning, that young people have rights, and those rights cannot be contested. Rights to information, rights to services, and rights to bodily autonomy and choices about what is done to themselves, to their bodies and their lives. We are not going to win this war. Secondly, we need to ensure that all these professionals within the system, from wherever we're talking about, whether it's teachers or health professionals, I think it's great what you're saying about mentoring the old and mentoring the young. I think that's important. But actually, if you're an older person in the health system or an older teacher in a school, you still have a responsibility to be youth friendly. I don't think we should give older people a get out of jail free card to say that they don't have a responsibility to understand the work they do from the perspective of young people. Because if we do, then they can get away with having archaic attitudes that are still an inhibitor to young people accessing information and services. So we must hold the older people to account as well in this respect. It's not just the responsibility of the young. But also we need to ensure that when we are really shifting the dial in all this integration and outcomes, that there is no need for any young person to access an unsafe abortion. There should be no need. If they have all the right services available to them at the appropriate time to make the decisions they need. One of the things I've noticed that is different between the health system in Africa to a great extent and overseas is when my daughter, who's now 19, was 13. It wasn't an SRH problem that she had, but she had a back problem, a spinal malfunction, dysfunction. So her spine was curving at a fast rate, and she was actually developing a hunchback and a problem with her back. Medical surgery was necessary to intervene, because if we left it as it was, it was going to affect not just her ability to breathe in her lungs, but it was going to affect her sexual reproductive health. So at age 16, a decision was made that there had to be a titanium rod put into her spine to straighten the spine and prevent her continuing to have a deformity, which would actually shorten her life in later years. A very difficult decision to make. But what I saw, different from when I was a patient when I was a patient myself in a country this country, because I'm Zimbabwean, and when I was a patient after a car accident and how I was dealt with, was in her case, the doctors and specialists at every stage would sit her down from the age she was 14, 15, 16, 17, 18. She had the 19, she's just been discharged right now. The operation took place when she was 17. But even before then, they would sit her down as a responsible teenager and speak to her. So while we might be in the room as her parents, they weren't talking to us, they were talking directly to her. And she was able to ask any question she wanted about what was happening to her body and what should be done about it and what the options were. She was given all the information. Do we do that in our health clinics and hospitals in Africa for any 13-year-old, 14-year-old, 15-year-old, 16-year-old, whatever the health issue is that they're presenting? These are lessons I think we must also take. So I think it's important and great that this work is being done across 4 countries. But also let's learn what others have learned in other parts of the world about how to treat young people as responsible people who care about their health, interested in their own health, and can make responsible decisions about their own health. Put the power back in the hands of young people, and we might be surprised at what this continent could achieve. So thank you very much for your strategic assessments. Thank you, Yvette, for your community perspective and also actually a healthcare perspective. And we wish to understand what happens as a result of this as you go forward in Botswana, Eswatini, Namibia with this work. Thank you very much, panelists.